This is Jose Merino, Editor-in-Chief of the Neurology family of journals. The Neurology podcast provides practical information to neurologists and other clinicians to help them provide better care for their patients. Thanks for listening and have a great week.
Hi, this is Trey Bateman from Virginia Commonwealth University in Richmond, Virginia. Today, I have the pleasure of interviewing Dave Jones, who's a behavioral neurologist at the Mayo Clinic in Rochester, Minnesota, as well as the director of the Department of Neurology Artificial Intelligence Program. Dave is a senior author on a paper published online in Neurology on June 27, 2025, titled An FDG-PET-Based Machine Learning Framework to Support Neurologic Decision-Making in Alzheimer's Disease and Related Disorders. Dave, as you know, I'm a huge fan of the power of FDG-PET imaging in cognitive evaluation, so I'm really excited to talk to you today about this paper and StateViewer. Thanks for joining me today.
Thanks, Trey. It's great to be here.
So this work really centers around StateViewer, a clinical decision support system framework that helps with the interpretation of FDG PET scans in the evaluation and interpretation of those scans in the service of differential diagnosis of neurodegenerative diseases that affect cognition and behavior. I think most will be familiar with what FDG PET scans are, but many might have been told something like, well, it's really only useful to differentiate between Alzheimer's disease and frontotemporal dementia, or something along those lines in the past during their training. Before we jump into the paper, can you give our listeners a brief overview of why that might not be entirely correct and what the impetus was for developing a clinical decision support system like StateViewer?
I think FDG-PET is often pigeonholed as just a way to tell Alzheimer's disease from FTD because of the fact that the brain is usually more affected in the front versus the back in FTD and vice versa in AD. But that really undersells its value and mischaracterizes the nuance of functional neuroanatomy that's relevant to the symptoms our patients are experiencing. FDG-PET really is a readout of brain network function. It captures the underlying physiology of cognition, not just proteins. So when interpreted correctly, it can differentiate a much broader range of neurodegenerative syndromes because each one disrupts brain function and brain networks in distinct ways. It's a crucial aid in the core neurologic practice of localization, which can be very complex for perceptual, cognitive, emotional, and behavioral symptoms that our patients are coming to us for help with. The problem is that interpreting those localizing patterns requires a high level of expertise and exposure to thousands of images, coupled with detailed clinical assessments and knowledge of functional neuroanatomy. And even then, experts are limited in how consistently they can recognize those subtle variations in distributed patterns for thousands of scans. And StateViewer was really born from that gap. We had been using FDG-PET as part of routine clinical care to support complex decision-making for our patients, but we realized that with AI, we could build a tool that captures the full complexity of those patterns, standardizes the interpretations, and gives clinicians quantitative evidence for what syndromes a scan most resembles, even if the clinician had not yet been exposed to all those patterns in their own practice. Personally, it came from years of working with patients who didn't fit neatly into categories and seeing how even experienced clinicians could disagree. So I wanted to build something that was scalable, transparent, objective, and actually help with those real-world gray zone cases. It's something I love using in my own practice to provide the best care that I can.
The interpretation of scans without that expertise can sometimes lead to really confusing results in clinical practice. So it sounds like this is something that starts to try to help get around that problem and give us some more useful reads that may give more precise information about the underlying diseases and syndromes we're seeing. Let's dive into the paper a bit now. So my understanding of this work is that you drew research participants from several sources: the Mayo Clinic Study of Aging, the Alzheimer's Disease Research Center, and the Neurodegenerative Research Group there at Mayo, as well as patients seen in the Neurology clinic. Within each of those groups, you had patients who had clear clinical syndromes or phenotypes, as well as those randomly chosen from the clinic, but without retrieving their health record data. A subset had neuropathological information to compare against as the gold standard of underlying etiology. And importantly, each of these patients had to have an FDG PET scan since that's the main input for StateViewer. And you ended up with just over 3,600 patients after quality control and everything, got rid of some that didn't have adequate scans. Next part is really novel, and what's the engine behind this work? And that's the machine learning model used to analyze those FDG PET images. I think machine learning can be intimidating to try and understand. Can you give us a simple explanation for what this model does and how this works for you in clinic? What would the output look like, and how does it help you arrive at better diagnoses for patients?
All this model needs is an FDG PET scan. That's the only input. It doesn't require any other piece of data. And then the model compares this particular patient scan to thousands of other well-characterized labeled scans with known diagnoses and outcomes. It finds ones that are most similar using some computer processing of the FDG PET. And then it returns a similarity score for each disease. I sometimes tell people it finds a brain like yours in our database. So we know if we've seen patients with similar symptoms or brain patterns to yours in the past. So sometimes I'll call this a brain like mine algorithm. For example, it might tell you this scan looks 85% similar to scans labeled as posterior cortical atrophy, and maybe 10% similar to DLB. And that helps reframe how we think about diagnoses, not as binary labels, but as similarity within a disease spectrum. Clinically, I pull it up in the patient chart. It shows a heat map of the metabolic changes, a ranked list of similar disease classes. It even lets you visually explore the most similar cases in the reference database, so you can see if those cases really look like yours. It's not a black box because it gives you high quality data individualized to the current patient to help the clinician actually think about the current patient.
When you applied this model to a group with a bunch of different potential diagnoses, how well did it do in classifying those? And did it do equally well across those, or were there some diagnoses that were more difficult than others for the model?
That's one of the amazing things. We looked at 9 different phenotypes, and there's just distinct information about all these different clinical disorders in the FDG PET, and it did really well across the board. This included typical and atypical presentations of Alzheimer's disease, the FTD spectrum, and DLB. And we're also able to show that these predictions aligned well with available pathology data, which is important. So it's not just replicating clinical labels, it's really tracking with multiple measures of core biology to these diseases. And the performance was strongest for more distinct syndromes like posterior cortical atrophy, DLB, semantic variant primary progressive aphasia. In fact, pretty amazingly, it separates all the major PPA classes, semantic, non-fluent, and logopenic, which can sometimes be difficult to tease apart just based on the clinical language features. The model had a little bit more trouble with clinical syndromes that have very different underlying pathologies. Things like cortical basal syndrome, which oftentimes can be due to underlying Alzheimer's disease, but may also be due to underlying cortical basal degeneration. However, when you see the way the data is presented, most clinicians will understand this and come to the right conclusions for themselves.
So you also put the model to a test in the radiologic reader study portion of the paper, where a really common clinical problem that we see a lot is differentiating between posterior cortical atrophy and dementia with Lewy bodies based on the scan presentation. And you can see there's some overlapping symptoms. And so this can be a difficult clinical distinction to make. They both have prominent posterior changes on FDG PET in the occipital cortex. And I've personally seen a lot of disagreement in reports on whether something is more consistent with posterior cortical atrophy or dementia with Lewy bodies. You compared a pretty typical workflow that included quantitative cortical surface projections against a workflow that only included reports generated by StateViewer. How did StateViewer do? Are we all getting ready to be out of a job yet?
So I think we'll still all be in a job for a long time to come. But this really was one of the most satisfying parts of the study because it tested whether the tool can actually help real clinicians with a current problem, which is especially hard. A visual reading task like distinguishing dementia with Lewy bodies from posterior cortical atrophy. They can look pretty similar. So we gave radiologists two workflows, one using a traditional cortical projections and another using just StateViewer reports. And what we found is that StateViewer significantly increased the odds of reaching the correct diagnosis, especially among less experienced readers. On average, it increased the odds of the correct read by about 3.3 times, and they could do it about 50% faster. So it doesn't really replace expert judgment, but it did augment it, giving readers a consistent quantitative framework, and it leveled the playing field across a range of expertise from novice to kind of world expert level. And the best performer was actually our most experienced reader in conjunction with StateViewer, which did even better than the model itself. So it's pretty clear we're not out of a job by any stretch of the imagination, but hopefully we're getting better at it with these types of tools.
If I'm remembering correctly, the benefit also seemed to be largest for those with the least amount of experience, or the more novice radiologists. Am I remembering that correctly?
That's absolutely right. So people at trainee level haven't had a lot of experience reading scans yet, but giving them the tool, they can perform better than expert level.
That seems like a really impressive feat and something that I think could really bring this type of expert diagnostic information and maybe democratize it a little bit. That seems like something that would be really powerful to see. In the remaining seconds that we have here, could you summarize for me the key take-home message that you want to remember about your work here?
I think the key here is that StateViewer brings a quantitative, objective consistency and scale to FDG-PET interpretation. It's not about replacing expert intuition. It's about enhancing it with transparent, data-driven insights. In an era where treatment decisions, prognostication, and patient counseling increasingly depend on getting the diagnosis right, tools like this are essential to ensure patients receive the most accurate diagnosis and ultimately the best possible care.
Thank you, Dave, for sharing your findings with us. I know I'd love to see StateViewer in use to a wider audience, including my own clinic workflow. And it seems like this is a really important step towards that eventuality.
We built StateViewer to bring more precision and clarity to the diagnostic process, not just for academic centers, but for everyday clinical practice. Our hope is that by making advanced tools like this more accessible, we can improve diagnostic accuracy, reduce uncertainty, and ultimately help more patients get the care they need earlier and with greater confidence.
I've been speaking with Dave Jones, senior author on the paper titled An FDG-PET-Based Machine Learning Framework to Support Neurologic Decision-Making in Alzheimer's Disease and Related Disorders, which I would encourage everyone to read in neurology.
This is Stacey Clardy, your podcast editor. If you've enjoyed the podcast, please take a few moments to subscribe, rate, and review the Neurology podcast through Apple Podcasts, Google Podcasts, Spotify, or wherever you listen. And remember, you can always head to neurology.org/podcast for our full list of past episodes. Or you can also search by keyword in your podcast app for any neurology-specific topics you want to learn about.